Hello and welcome to another edition of Cardiac Imaging Agora. In this session, we will have a discussion on how to read a cardiac PET in the setting of prior CABG. Patients with prior revascularization, especially surgical revascularization, they pose some challenges for the traditional reading of a SPECT. First, the anatomic landmarks of various coronary arteries are not applicable. So we know what's, in general, what's an LAD territory, what's an RCA territory, what's a CIRC territory. However, once you start doing bypasses, you can have partial defects or reversible defects, fixed defects in segmental fashion that are not contiguous because some areas are, there is a bridge that covers that territory, so for the areas proximal to it are not covered, and you end up with defects. EKG changes on stress EKG usually do not help us a lot because there's often non-specific post-revascularization. You have abnormal septal motion in patients with prior CABG. Also, more often these patients have prior infarct, so there is resting wall motion abnormality that will not help you if you have issues of attenuation. Flow and flow reserves are not well validated in patients post-revascularization. And this is not because the technology is not there, it's because revascularization complete revascularization is in the eyes of the beholder. Also, the next point is correlation with angiographic results may be challenging, and we'll show you an example of that today. Again, we go back to our laundry list of steps we follow in reading these images. This is today is going to be a PET scan, so therefore we go with the transmission emission images first, and we follow all these steps till we generate a clinically meaningful report. So this is, I will start with the history in an unusual fashion because with patients prior revascularization, I would like to know a little bit about the patients when I'm reading the scan because the pretest likelihood of disease is 100%. So this is not made for diagnosis. This is made in general for estimation of ischemia. So we're not here biased as far as pretest likelihood of disease. The pretest likelihood of disease is 100%. The patients have disease. So a 78-year-old male with history of CAD. I saw this patient in the past few days. He had a bypass 11 years earlier, PCI 7 years earlier. He was on dual antiplatelet therapy, beta blockers, ARBs, statins, and spironolactone. He's had history of paroxysmal atrial fibrillation on anticoagulation, on NOACs. He had an aortic valve replacement 3 years earlier. At that time, his grafts were patent. Now he comes with chest pain and dyspnea and exertion. The left ventricular ejection fraction was called normal by echo, and the aortic valve mean gradient was 12 millimeters. So you cannot attribute the shortness of breath or chest pain to the valve. The valve is functioning well. By the way, his bypass was a Lima left intermammary graft to the left anterior descending artery, a vein graft to the circumflex, and a vein graft to the RCA. All these grafts were patent at the time of the aortic valve replacement 3 years earlier. This is his EKG. His EKG shows normal sinus rhythm, very prolonged first degree AV block. You can see it right here. And nothing really unusual, no major areas, no major Q waves in the inferior leads or anywhere else. You have some septal cues here, but they're not consistent in the rest of the EKG. So we go to the echocardiogram. This guy's BMI is 45. So we did the echo with, of course, with contrast, as you can see here. Again, you can see in the apical 4-chamber, apical 2-chamber, normal ejection fraction, a normal wall motion, maybe a little bit of a septal wall motion abnormality, but in general, it's all okay. Then we go to our images. This is a regadenoson PET pharmacological stress test. We have 3 sets of images in this patient. We have the rest images done here. Again, this is the intent of this is to go over the co-registration of the images. We have the stress images right here. Again, co-registration of the perfusion images versus CT images. And then we have the FDG images that were performed in this patient. Again, the same rationale is look for co-registration. And here you can see a small pleural effusion on the right side. We move next to the reconstruction planes. rest and stress, rest on the bottom, stress on top. Again, you can see here beautifully the software detecting at least on the perfusion images, the reconstruction plane. We don't have to do much here. And then once you have FDG images, you also have to point the system to the FDG images here. So the FDG is on the bottom right here, and the rest images are on top right here. Now we go to simplify our life. So I never look at all these images together. So I don't look at the rest, stress, and FDG all together. I look at the rest and stress. First, it's much simpler. It's a better way to assess ischemia, fixed defects. So don't confuse yourself and put all the images together on the same screen. So we have rest and stress here on the rest images. We have in the short axis a very minor mild perfusion defect in the septum. You see it here, and you see it here compared to the lateral wall. On the stress images, this defect becomes severe. Now the entire septum, you can see it basal and mid-septum. You can see it here in short axis. Again, the septum becomes severe. And one more thing, if you look, if you pay attention, not that distracted by the severity of the defect in the septum, you can see the inferior wall here becomes ischemic too. You can see it here in the short axis, and you can see it here in the vertical long axis too. The next step for me is to look at the rest and FDG images. This is another view with different color scheme, just to impress on you the size of this the size and the severity of the reversible defect, indicating ischemia right here in the short axis, right here in the horizontal long axis, and right here in the vertical long axis. We score these segments. So we go here, we have a very mild defect in the inferior septum. We put ones here for mild defect on the polar maps with 17 segment, the traditional recommended 17 segment model. And then we have here the 17 segment model for the stress images, and we score these defects based on severity and location. You can see the inferior wall here, we scored it. Inferior septum is severe, anterior wall here, and anterolateral wall here. Remarkably here, as you can see, you have the sparing of the apex, which doesn't make sense if you're thinking about an LAD territory ischemia, but you have to remember that these patients have a bypass, the lima to the LAD, so the distal segments are protected by that lima to the LAD, whereas the proximal segments are still trapped within that obstructed zone in the LAD, if I may say that. So again, this is the area of the defect. So this is not what we usually see in a person who's never been revascularized. Usually the defects are worse distally and less prominent proximally. Then we look at that at the rest and FDG images. You can see that mild defect here in the septum that was present on the rest images now picks up FDG beautifully here. So this probably represents an area of resting ischemia or resting hibernation, very small area, although also you can see it also the inferior wall right here. You have FDG uptake in the same area where we called ischemia, if you recall. So I'm going to show you next. Very nice, actually, depiction of what does it mean for the FDG uptake. These are the rest images here, depicted right here in 17 segment model. Stress images right here. This is the FDG images, and look at the FDG, how well it tracks the area of reversibility. So this is the area of ischemia here in the far right, and this is the area of FDG uptake. So what we're dealing with here is a couple of things. We're dealing with the area of probably some resting ischemia in the inferior septum right here. And then we're dealing with area with what has been called for a long time ischemic memory. So the way we do our tests is we do the rest images first, then we do the stress images, then we do the FDG. So what we call, when we stress this patient, we cause some ischemia here, some true ischemia, not only differential perfusion on the PET. And therefore, when we went back to do the FDG images, we still were able to pick that area where the myocardial metabolism has shifted from fatty acid to glucose. Or the patient came to our lab with repetitive areas of ischemia and walking around, probably when basically doing his own stress test on a daily basis. So this is what's been very well characterized in the literature, pre-ischemic conditioning. So this is an area here where the FDG actually, this area maybe permanently, or at least at the time when we image the patient, has shifted its metabolism to preferentially FDG. And again, very nice area. What you can use this actually is an insurance policy almost when you're doing rest and stress images and you see that much area of ischemia, that this is not artifactual by doing the FDG. If the FDG is there, so this is basically, it tells you exactly that this is ischemia for sure, and this is not an artifact. So the FDG can act as a physiologic marker of resting ischemia, ischemic memory, and insurance that you read the scan correctly by calling the area of ischemia. This is not artifactual due to a motion or a problem there. It's more likely to happen on a SPECT image than a PET, but in this instance, we have a PET image here. Again, I don't want to belabor the point, but this is a very good example of the area of ischemia and the area of, the area of ischemia here on the far right, and the area of FDG uptake are exactly the same. Then we go next to the gated images. So now we have rest images here. This is the histogram for the rest images. Heart rate was 64. Histogram for the stress images. The heart rate is 84 here. So now we make sure that these images are, again, we have good pickup of the boundaries of the heart. You can see on the rest scan, this was not a problem for the system to figure it out. On the stress images, because of the absence of the septum right here and the ischemic area, it misconstrued the right ventricular free wall actually as the septum and expanded that. So we have to make sure we pay attention to that if we have a large area of ischemia. So basically we zoomed in on the left ventricle, and you can see it in the right side here. Now we can actually process the images and generate the ejection fraction. You can see it right here. Although we don't have a major drop in the ejection fraction, we have a major increase in left ventricular size here. The blue is the rest images, the orange is the stress images, and you can see here the ventricle in all end-systole and diastole increased in size. So we have some TID. What we can see here visually also, you can see the images here versus here, significant increase in the left ventricular size from rest to stress. Again, we look at the dyssynchrony analysis up here. You will see the normal patient, a normal example of dyssynchrony, since most of you guys don't look at dyssynchrony on a daily basis. And this is our patient here. And you can see this dark green here is the septum, and the septum is completely dysynchronous. And this patient, both at rest and stress. So even before we provoked ischemia on the stress images, we have septal dyssynchrony. I said earlier, we do not do flow ratios on patients post-CABG because it's not been validated. We do it just for in terms of research purposes and data collection. The LAD myocardial blood flow reserve was 1.1. Normal is below 1.8, 1.7. RCA was 0.92, indicating steal in the RCA. Circumflex was 1.53, and this reflects what we saw because the area in the circumflex, or the territory of the circumflex coronary artery, was not as much affected by ischemia, at least from the visual inspection of the images, with a global flow reserve of very severely depressed at 1.22 in this patient. And then we looked at the CT images. You can see a lot of calcium here. This is the aortic valve replacement, calcium in the right coronary artery, calcium in the distal LAD. Not a surprise in a patient who had a prior bypass. And again, we have this pleural event here. We go to generate the report. We report again the dose given. This is a relatively higher dose because we do CT attenuation correction for the rest, stress, and FDG images. So that's hence the DLP is higher here than a traditional scan. The indication for this test was to assess ischemia and viability or in a cardiomyopathy patient. We put the dose given for all three, for the rubidium, rest, and stress, and then for the FDG, as well as the resting blood sugar at the time of the scan. That's all quality assurance purposes. Again, one thing here, I just want to show you how fast you can do these tests. This is the rest scan done at 8:42 a.m., the stress scan done at 8:58 a.m., or the dose given at 8:50 a.m. So you can do the whole rest and stress sequence in under 25 minutes. From the minute you get the patient on the table to the minute the patient leaves the lab, If you don't have the FDG images, under 25-minute rest and stress images, one setting, they don't have to get up, go back, come back, sit in the lobby, wait, none of these things. This is within 25 minutes, you're done with the scan. So I would say, compared to traditional SPECT, not CZT SPECT, this is an ultra-fast image. Then we fill up the clinical part of the exam. This is a patient I told you before. His BMI is 45. These are his risk factors. Again, we talked about his prior CABG, prior PCI, aortic valve replacement, and so on and so forth. The patient had some ST depression, had chest pain during the test. This is again a regadenoson stress test. We fill up the data for the rest and stress images. Again, the volumes here are incorrect because this is a QA issue. The volumes that were put in here are the volumes derived from the system misconstruing the right ventricular free wall as part of the exam. I kept it here just to show you how if you just trust the system and click transfer the data, you can end up with a huge data error. Although the EF looks fine, you can see here the ventricular and systolic and diastolic volume are huge, which is not true. So this is combining both the LV and RV and the volumes because the septum is absent. We fill the scan. Again, we already coded this part. It shows up here in our database. So a physician who's referring the patient can see it, can see exactly what we called and where we called it. And then we call this area ischemia in the LAD. There's anterolateral ischemia, we call it part in the circ, and the RCA. We called no scar here because this area of uptake here, we call it all ischemic. So there's no hibernation scar. You can call this hibernation if you want, this part here, but the problem is you end up double counting because you already called it significantly ischemia. Now, sometimes I can modify my report and say there is a combination of ischemia and hibernation in the inferior septum, just to reflect what we saw on the FDG and the inferior septum, because we have a very mild baseline defect. But in this instance, we decided to call it severe ischemia. We stopped there. It doesn't make any difference in terms of total myocardium at risk. It's still the same. This area is going to be, we don't want to double count it. And you can see here the TID is 1.41, so this ventricle dilated significantly. So again, this is the conclusion of the report that the referring physician would see. Ischemia in all the 3 coronary territories. Also, although you saw that the apex was spared, so now we have to figure out how to correlate this with an angiogram. So here's the angiogram on this patient. This is the right coronary artery, totally occluded, as you can see here, with late filling of distally. The vein graft to the RCA was totally occluded, so I'm not going to show you a picture of that, and that probably explains why we have ischemia in the right coronary territory distribution. This is the left main shot, and you can see the LAD also is proximally occluded. You have now disease here in the distal part here of the circumflex coronary artery, and you can see filling via collaterals here of coming back right here. You have some competitive flow also here. If you pay attention to it, it will show later. So now we go, and this is the vein graft to the circumflex coronary artery. Patent, no problem. Hence, the infralateral wall was spared with no problem as far as ischemia. And then here's the lima of the left anterior mammary graft artery to the left anterior descending artery, widely patent to the distal part, which supports what we saw on the scan. However, if you pay attention to the proximal segments of the left anterior descending artery, they're all trapped within this ischemic zone. So these are the septal branches, all here severely diseased. Despite the fact that you have a patent graft distally, proximally, everything is ischemic and trapped within this obstructive coronary disease area here. The diagonals too are there. So just to sum up what we just talked about, so we often talk about the concept of complete revascularization. I think it's more aspirational, despite the fact that this patient at baseline had complete revascularization. All 3 coronary territories were revascularized. You can see there's no way of going around the proximal disease in the vessel, especially in the LAD. Now, later on, years later, the vein grafts to the RCA went down and caused some problems too. But even when we attempted that complete revascularization and succeeded at it, at least surgically, you can still see that the anatomy is almost destiny. So if you have severe disease proximally, that's not going to be solved by complete revascularization distally. The anatomic landmarks of various coronary arteries are not applicable. You can see here a mishmash of segmental ischemia with sparing of the apex. The defects are not contiguous, so you don't have severe ischemia in the apical anterior wall and less ischemia proximally. The ischemia is more proximal and no ischemia distally, so the segments that are ischemic are not contiguous. The EKG changes in this instance reflected probably some problem, but usually they're not helpful post-CABG. Abnormal septal motion, this could be ischemic changes versus post-CABG abnormal septal motion. Flow and flow reserves are not well validated, but in this instance, they reflected the situation that we are dealing with beautifully, but you cannot rely on that because revascularization in these patients post-CABG can be variable, can depend on targets, can depend on what vessels you use. Do you use veins? Do you use arteries? How long do you do it after revascularization? What about branch vessels? Were they revascularized or not? So it's very difficult to interpret in the setting of CABG. And the correlation with angiographic results may be challenging. So if you get a call from your colleagues in interventional saying everything is patent and there's no problem here, that can be true, but the problem is the grafts are all patent, but the native vessels are diseased and they're not allowing the blood supplied by the grafts to go backwards and fill the areas that have obstructive disease. So the correlation with angiographic results is challenging. So the definition for most interventionalists is there's nothing for me, there's nothing here that's a problem, is because there's nothing to open. But for us, if you look at this example here, you can see that Lima is widely patent. So in the view of the interventionalist, there's really no problem. But you can see that the proximal part of the coronary artery is the problem here, the native coronary artery, and not allowing the blood supply to the diagonal and the septal territories. Again, keep this concept in mind, the concept of ischemia right here, rest, stress, and the concept, this is the reversibility and the FDG area. So this concept of ischemic memory, resting ischemia, repetitive stunning, switching the myocardium to FDG uptake is very helpful and conceptually attractive to not only understand what's going on with the patient who's probably having repetitive ischemia walking around, but also to QA your scan when you're reading ischemia and figure out, wow, I called ischemia exactly where the FDG uptake is. Therefore, this is not an artifact. This is real. Thank you for listening to this edition of Cardiac Imaging Agora, and we'll see you in another session. Thank you.